and welcome to Changing the Ovarian Cancer Story from the World Ovarian Cancer Coalition. Together, we are shining a light on the most lethal of female cancers, looking at the challenges and the successes, both big and small. I'm your host, Hannah Vaughan Jones, and we're going to dive straight into season 2. Thank you so much for coming along for the journey so far. Now, many women are now speaking up about their experience leading up to an ovarian cancer diagnosis, but sometimes the signs aren't only physical, they're hidden in family trees. About 1 in 5 ovarian cancers are linked to inherited genetic mutations. You can't see a genetic mutation, you can't feel it, but crucially, you can test for it. Now, in this episode, we're going to look at inherited risk, early detection, and the options available today, and what the future might hold through projects like DISARM, a European initiative aiming to improve risk assessment and prevention for women. So, let me introduce our guests. Tamara Hussong Milagre is the president and founder of patient association Evita in Portugal and has an incredible personal story of genetic testing and preventative surgery. Professor Adam Rosenthal is a consultant gynecologist at University College London Hospitals, UCLH, where he leads the Inherited Gynecological Cancer Surgical Prevention Programme. And from Brussels, we're joined by MEP Stine Bosse, who is a co-chair of the MEPs for Women's Health Group. Welcome to all of you. It's so great to have you here on the podcast. I want to start off, Tamara, if I may, by asking you to take us a little bit back to the time when you first discovered that you carried this BRCA mutation. How did you find out? And what does that feel like to know that you carry a genetic mutation that significantly increases your cancer risk?
So thank you so much for the question, which is very important so people understand the hints for a possible syndrome in a family. So back in 2008, I was taking care as a nurse in our hospital. I was taking care of a young woman, 27-year-old pregnant lady. She was pregnant with her second daughter, and she came to us with 29 weeks of pregnancy and a highly advanced breast cancer. So she got a mastectomy in our hospital, and when I took care of her in the recovery room and I was listening to the baby's heartbeat and looking at her and seeing this mutilated woman, I was asking myself, what happened here? She's 27 years old. I never heard of something about like that. She's too young to have breast cancer. And then I followed up her doctor appointments, and she told me, I felt the lump in the beginning of the pregnancy. I told my doctor there is a lump in my breast, and he was just laughing at me and said, "Child, you are way too young to have breast cancer. Those are changes due to pregnancy. So just relax and let me take care of you." And this ignorance from her doctor cost her life 2 years afterwards. So when she was dying, I promised her that this would not happen to her daughters nor to mine because of her family history of cancer. She told me 2 aunts on my paternal side had died of breast cancer at 40 years of age. And I thought, okay, what's got that to do with your personal risk from the paternal side? Because my paternal aunts, they had breast and ovarian cancer at that age. And my paternal grandmother died of ovarian cancer. I remember I was a very little child and my parents took me to my paternal grandmother to pass holiday season there some days. And I didn't want to be around her because she was in such a pain and suffering all day. I didn't want to be around her. I didn't understand that she was suffering from a very aggressive and painful disease. And at the time, we did not have the pain meds we have nowadays, fortunately. But I remember my paternal grandmother for me was always something dark, somebody with a huge suffering. And then slowly it made light. So I understood I have myself a very strong family history of breast and ovarian cancer on my paternal side. And additionally, I had my mother who had breast cancer at 44 years of age. So of course, when the BRCA1 mutation was diagnosed at that a young breast cancer patient in our hospital, I rushed to our medical geneticist for genetic counseling, and I said, I heard there is such a thing like mutation due to genetic predisposition. I may have inherited something from my father's side. Is that true? And they looked at my family history and they said, okay, we need to do genetic testing. This is a very strong family history.
Mm-hmm.
Also, I have 2 daughters, So I did the test, and that was the way I found out actually that I was a BRCA1 carrier. And then I got the chance to do something about it. I was much more lucky than my friend.
Yeah. And I want to come into the what you did about it as well and how you dealt with that information. I want to bring all of that into this conversation. But Professor Rosenthal, Adam, before we move on any further, I think there will be a lot of people listening to this, like me as well, who don't understand these terms BRCA, BRCA1, BRCA2 and mutations and what does it mean? It all sounds quite scary. Can you explain in simple terms, in layman's terms, what are these mutations and how do they increase ovarian cancer risk?
Sure. So there's a number of genes of which BRCA1 and BRCA2, so BRCA1 and BRCA2 as they're commonly known, are the best known. And they're best known ones probably because Angelina Jolie, the actress, went public with this many years ago on the cover of Time magazine. So a lot of people around the world have heard of BRCA1 and BRCA2, but there are some other genes which can also increase risk. Now, these genes can be inherited from your mother or your father's side, and this is really crucial to understand because so often we hear tragic stories of women and even their healthcare professionals thinking that because something came, or because the history of cancer was on the father's side, it wasn't relevant to her as a woman because your dad's a man, not a woman. That's wrong. It can come from either side of the family. So you mustn't assume that just because it's all your paternal aunts and uncles and grandparents that have had various kinds of cancers, that's not relevant to you as a woman. It is relevant to you, whichever side it comes from. And if you've inherited one of these genes, that means every cell in your body has one copy of the gene that doesn't work. We have 2 copies of all of the non-sex determining genes in our bodies. And one copy comes from your mum one side, one copy comes from your dad's side. And if you're born where every cell in your body is lacking one of the function of one of these genes because it's been mutated, it's not doing its job properly, if you like, then that means as you get older, it's more likely that the other healthy copy gets damaged just by environmental factors, just by getting older, possibly by ovulation, which is one of the theories as to why there may be a higher risk of ovarian cancer with women who have BRCA1 or BRCA2 gene alterations. So the crucial thing there is not only are you more likely to get a cancer than someone who doesn't carry one of these alterations, but the other crucial thing is that it can occur at a younger age. And typically, ovarian cancer in the general population is a disease of postmenopausal women. That's women usually over the age of around 51. But if you have a BRCA1 gene in particular, and that is probably the single worst gene to have in terms of your risk of ovarian cancer, then your risk begins to increase above the age of 35, and around 1 in 8 of the women who develop an ovarian cancer because of a BRCA gene alteration will get it when they're premenopausal, so when they're young, between the ages typically of 35 and 51. So that's a terrible burden for them because if you're going to do something about it, that's going to have a bigger impact on their life than if they're already postmenopausal.
Thank you so much for sort of explaining that so clearly for us. Tamara, do you mind me asking how old you were when you found out that you had this particular genetic mutation, and then what you did about it, which, from what I've read, and I hope you don't mind us asking you to sort of go into the detail of how you made that decision, but you went ahead with preventative surgery, correct?
Correct. So I actually was already 41 years old when I found out, and I felt that cancer was just lurking around the corner, because everybody that was carrier of the paternal mutation because after I found out, I immediately called my then ovarian cancer survivor aunt in Germany. I'm based in Lisbon since 28 years, but I'm German originally. So I called her in Germany and I told her, did you know that we have a BRCA1 mutation in our family? And she said, yeah, we know since 2 years. And I said, thank you for not telling me, because I could be dead right now, right? And she said, you can't imagine what we experienced when we tried to communicate with your uncles about the mutation, because the family, and this is now my reading afterwards, after being enlightened, now I understand why they rejected aggressively to talk about it, because they were so traumatized about suffering and early death due to cancer in the family, because the sisters all died of hereditary cancer. The mother had died of cancer. So they were really totally afraid and paralyzed by the disease, and they didn't want to talk about it. So my aunt cut off the communication on that point. And I was lucky to find out. And then I thought, okay, it's not worth anything to continue angry with my aunt. Just need to go forward is the way. What are we going to do next? So for me, it was clear when I was waiting during the blood sample until the test result. I had 3 months to think about the consequences. And when you have this very strong family on a paternal side, so everybody, and later my father died of prostate cancer. So everybody of the whole generation died with hereditary cancer. Additionally, I had my mother at 44, her first breast cancer diagnosis. For me, at the time, with the paternal mutation confirmed, there was no discussion regarding the risk-reducing surgeries, because I can undergo personalized screening, which starts way before the populational screening, because as Professor Rosenthal said very well, of course, early onset of disease in genetic mutations is very typical.
Right.
So I didn't want to wait for the cancer to catch me by surprise. I had little daughters to take care of. I wanted to see them grow up and be there for them. So I advanced immediately with the double mastectomy, which for me was purely a cosmetic situation. It was not necessary to have a good quality of life. I was way much afraid of the ovarectomy because of the early onset surgical menopause, which implicates strongly with our quality of life. And it's 10 years before it's supposed to be. You go into menopause from one day to the other. My doctor asked me if she should give me a PET already inside the operation room after taking out my ovaries. And I said, no, let me feel it. I had one day to feel it, the next night in a very strong hot flash. I never felt something like that ever again. And I said the next day, please put 2 of those things there, please, because I don't want to go through this again.
So did you have the preventative surgery? It sounds like you had everything that was available.
I had everything, and additionally to the bilateral ovarectomy, which is taking out both tubes and both ovaries, I also decided to take out my uterus. At the time, there was a study coming out regarding a rare but quite aggressive endometrial cancer related to BRCA1 mutation. And the other thing is, as a nurse, I was working in the gynecology, in the hysteroscopies, and I understood without the hormonal stimulation of the ovaries, the uterus is also not really doing anything than taking its space there and causing problems afterwards to go to hysteroscopy. So I decided for myself, and because I wanted to take only one hormone as a replacement therapy, so I did my research as a nurse. I had this medical background. I did my research and I understood the lowest dose of only one, which is estrogen, transdermal through the patch is the less invasive form with the most effective outcome related to quality of life for me.
Okay.
So this was my personalized decision. And, you sometimes need to convince the doctors that are going to operate on you because they do not have this background yet. The specific case of BRCA1 back in 2008, years before Angelina Jolie, there was no genetic literacy at all out there.
I mean, Tamara, you clearly are able to advocate for yourself. You were in arguably a stronger position just because of your medical background and your nursing training anyway. And you sound like someone who would be more than capable, of being able to advocate for themselves in front of a physician and the like. There will be lots of people who feel they have less understanding, they're less educated about medicine and health and what's available and what's not. Adam, can you tell us, if someone has or finds out that they have one of these genetic mutations in their family history, is it still personalized to them? Does everyone have their own particular genetic formation that means that just because someone has BRCA1 and someone else has BRCA1, it doesn't mean that they're both have exactly the same chances of developing a cancer later down the line? Is it still very much personalized? And it's not just a case of you have this and therefore the only option is preventative surgery because you are going to get this. There is a 70% chance that you are going to get this.
So first of all, to be clear, if, for example, your mother has a BRCA1 gene alteration, it's 50-50 whether you get the good copy or the bad copy from her. So it's not inevitable that just because your mother or sister has a gene alteration that you have it as well. So to begin with, it has to be personalized in that you need to be tested first for that exact same gene alteration, which is usually pretty quick and easy to do once you know which gene it is that's affected and which particular part of the gene is affected. It's then quicker, easier and cheaper to test the blood relatives to see if they have exactly the same mutation. But once you know you've got that particular mutation, there are some things that are now beginning to come to the forefront in terms of helping us to provide a more personalized approach to how that woman might want to manage her risk and what her options might be. And this is because we know from quite large epidemiological studies that there are certain things that influence the risk of ovarian cancer in both the general public, but also in BRCA1 and BRCA2 carriers. For example, the more children you have had, or the more years you've used the combined oral contraceptive pill for, the lower your risk of ovarian cancer. And unfortunately, these things don't yet get to a point of accuracy where we can say, well, you've had 5 kids, you've used the pill for 15 years, so your risk is so low we don't need to operate. It's not got to that point yet, I'm afraid. There may be a minority of BRCA carriers in whom, with not just the epidemiological evidence, their reproductive history being taken into account, but also wider genetic testing, not just for BRCA in that patient, but looking at things called signal nucleotide polymorphisms, which I won't bore you with, but these are other genetic markers of risk of many diseases. It's a bit like, imagine you've got a deck of cards, 52 cards, and if you get the royal straight flush on that deck of cards playing poker, maybe that means you're never going to get ovarian cancer. We're not quite at that point yet, but it could be that in the next sort of 5 to 10 years, we're getting increasing accuracy from all of these other bits of information that we can actually change the advice about whether to have surgery or not would be a real holy grail in this idea. But if not that precise, then at least your risk in the next 5 years is so low you could safely put off the surgery, that kind of thing, which I think is really crucial to decision making. And there are now software programs available. There's one made from Cambridge University in the UK that's already entered clinical practice in the UK called CanRisk, which is integrating the genetic test results with the reproductive history in terms of how many children a woman has had, how many years pill use she's had, that kind of information, to try and come up with a more personalized risk score that might help the woman decide at what age she wants to go through the surgery with the inevitable premature menopause that accompanies it.
I think this is fascinating. And for a lot of people listening, and myself included on this, I think one of the scariest things is that you finally listen to a podcast like this and you finally know that you need to advocate for yourself. You need to go to your GP and you need to go and get tested because you've got X number of people in your family history on both your mum and your dad's side who've had cancer in general. So you just want to find out how do you prove your eligibility for screening, for testing? How many cases do you have to have in the family, or how much family tree?
Well, that's going to be very, very dependent on which country you're in and what the local healthcare system is.
Right.
In the UK, it is tightly regulated within the National Health Service. But to be brutally honest, it's tightly regulated because it's not currently affordable to test just anybody.
Right.
So you have to hit a threshold before the National Health Service is willing to test you. And that threshold has come down over the last 20 years or so because it's become cheaper to do genetic testing. And there's more evidence now on the cost effectiveness of genetic testing because it's so much cheaper for the health service to identify people who are at increased risk so that they then undergo the risk-reducing surgery to stop them getting ovarian cancer, which is unbelievably expensive to treat because you have massive surgery, multiple courses of chemotherapy, now even more expensive targeted therapy like PARP inhibitors, which work particularly well in BRCA1 and 2 carriers. These drugs are a transforming outlook for women with ovarian cancer, but they're fantastically expensive. So you only have to prevent a few cases of ovarian cancer to save the health service a lot of money, and instead you use that money to lower the threshold at which you offer genetic testing so more women are able to find out their risk and do something about it. So that's not obviously just about saving money, it's about preventing human suffering and saving lives, and these are often young lives. So it's an absolute no-brainer to me that everyone should actually be eligible for it once they've made an informed choice about the pros and cons of finding out their risk. One other thing to mention is that you might think this is very easy. You could just go and pay for a private test. Just pay out of your own pocket to have someone do a test for you. But there are a few caveats about that. First of all, it's always more informative to test the relative who has cancer, because if you've got a very extensive history in the family, like Tamara has described, if she tests herself and she's negative, that doesn't prove there's nothing going on in the family. It only proves there's nothing going on for her if her mum or sister who had the cancer has got that gene alteration. And then if she gets tested and finds out she doesn't have her mum or sister's gene alteration that caused the cancer, then she's in the clear. I mean, she's still got the population level risk. Any woman has a 1 in 50 to 1 in 70 lifetime risk of ovarian cancer, but that's nothing like as bad as being a BRCA1 carrier when your risk is ballpark 1 in 2 in your lifetime, which is a completely different, huge increase in risk. So that's the one caveat. Don't necessarily go for yourself getting tested first. Try and persuade, without putting too much pressure on them, one of your relatives who's had a cancer to get tested, because it's much more informative for the family as a whole for the person with cancer to get tested first. But the other thing is you have to be careful about who's doing your gene testing and are they offering you suitable counselling before and after. Because you don't want to have some fly-by-night company that's doing poor quality testing that might miss a gene alteration because they're not doing enough of the different types of analysis that needs to be done by a high-quality laboratory. But also, if they're just going to give you a result, say you've got BRCA1, BRCA2, and then just leave you hanging with no avenues for what you then need to do about it, that's going to be deeply traumatizing for you, over and above the trauma you may feel being told you have a very high risk of cancer. So I think you have to be cautious about who you get to do your gene testing for you and whether you should be tested first or whether a member of your family who's got one of these cancers, like a breast cancer or an ovarian cancer, should be the first person to get tested.
And thank you. And Stine, I want to bring Stine Bosse into the conversation as well, please. Stine, let's look at this a little bit more through a policy lens as well. You are the co-chair of the MEPs for Women's Health group. Just give us a broader picture at the moment because we've been hearing from Tamara about her German and Portuguese background as well, and we've heard from Adam much more of a UK lens. But broadly speaking across Europe, is ovarian cancer even on the radar. And when we're talking about health structures, health systems as well, and whether the funds are there or the interest is there in research and turning that into actual practical usage for women, is there an appetite for this within the European Union?
Let me start by first of all saying I think it is so important, this kind of information sharing, that I really think this is. It's crucial that we, as females and as doctors, get these messages out much broader. So thank you very much for the initiative. And let me just also start by saying, when I learned about, where is women's health on a general note compared to men's health, I didn't believe, I was just like, that cannot be true. I mean, I'm 65. I never knew about this. I thought we were on par in these areas, which of course, obviously is not the situation. So let's start by saying all over Europe, there is now a much more educated discussion about the special themes within women's health. And that is about time. So let's keep that as a positive, but not rest on it. It needs to go much further. Then I noted carefully your story, Tamara, which was also about doctors not listening. And I listened to a colleague from Ireland. Ireland obviously have, I didn't know that, but they have worked a lot on the subject of women's health. And one of their findings, and I'll bet you anything that would go across the board of Europe, is that doctors didn't listen enough. So the women came out of the consultancy with the doctor and said, he didn't really understand me. He didn't really listen to what my problems were. And here I am now, the door's closed. So if we started, and that was where the road they took in Ireland, and if we all thought about that and started by really demanding that, and this is also up to us, I'm sorry, women, but it is. We have to demand that we are listened to. And then I think also, because, doctors probably like 9 out of 10 want to listen, but they just educate it in another way. So we have to demand that. So that's the first take from what I heard. And then I think the whole idea of thinking differently about screening, thinking differently about knowing that we should work with this so that would be an equal access for all women in Europe by the same standards, so we can educate women to say, if you have this story, and the doctors know, so if you have this story in your family, that should be your call to go and have a test. And that should be across the board again in Europe, how we should deal with this. And then I want to say, I really, and this goes for many, many areas for within health, but what we can do better and cheaper together, we must. Come on, let's get on board. Let's not discuss whether, is the authority there? Have we the right things in the treaties and all this? It really doesn't matter. What matters are lives saved.
Yeah, because there's a big obviously broad range of socioeconomic backgrounds and budgets and all the rest of it across the whole width of the EU, for one.
Yeah.
But the EU is also leading the charge, and let's move into a bit more of the kind of the response to this and the advocacy and the policy change. One particular program is called DISARM. Now, this is a 4-year funded European research initiative. Tamara, I know you can talk to us more about this particular project. It's something that the World Ovarian Cancer Coalition that's behind this podcast is also partnered with as well. And this is all about trying to improve risk assessment and therefore early detection as well. Tamara, tell us a little bit more about DISARM and what it's aiming to do ultimately, and also Evita, which is your patient-led organization, I understand, as well, out of Portugal.
Yeah, so within DISARM, we aim to prove that we can develop sustainable, affordable biomarker that helps us to detect way earlier ovarian cancer. As most of still nowadays in 2026, we do not really have a reliable biomarker for early detection of ovarian cancer. So we are, in fact, forced for surgical prevention, because most of ovarian cancer is only diagnosed at stage 3 or 4 when it's not cured.
It's too late.
Yeah, it's not
it's too late
anymore. You just wait for your next rest. Yeah.
Just before you carry on and finish your sentence, I'm so sorry for interrupting, but biomarker, just for those who aren't medically trained at all and are listening to this going, can you explain what a biomarker is?
It's a value in your blood work that it has a scale, and when it's over a certain amount, it's positive, and you have to look closer if there is a tumor developing already.
Okay. Does that sound good? Adam, is that a good example of a biomarker?
Yeah, that's pretty good. Can I come in briefly at this point and just say that in the UK now, we've just started at our own hospital rolling out a program of surveillance for women while they're waiting to get to the point where they're ready to have the surgery, because we feel that doing nothing while they're waiting to have the surgery is not appropriate, because we have actually got evidence from 2 US trials and 2 UK trials that using an algorithm, a piece of software that looks at the rate of change of a chemical called CA125, which is often used to help diagnose and monitor treatment response in ovarian cancer, can actually detect ovarian cancers earlier in BRCA carriers. Now, sadly, it doesn't detect everyone at stage 1, so it's not a safe alternative to the surgery. But roughly speaking, it halves the proportion of women diagnosed at stage 3 and stage 4. So it's better than doing nothing, because if you're diagnosed at stage 1 or stage 2, you're almost certainly still going to need chemotherapy and possibly targeted agents, but also you get away with much less aggressive surgery. You maybe need to have a hysterectomy, remove of the tubes and ovaries and the omentum, but you're unlikely to need really unpleasant things like bowel resections and colostomies. So there is a benefit to being on this surveillance in our view, and that was endorsed by the National Institute for Health and Care Excellence in the UK, or NICE as it's known. It should not be used as a reason to put off the surgery forever, though, and that is really crucial to understand. The women must not be lulled into a false sense of security by the tests being normal, and you need to have an annual conversation with that woman, reminding her about her risk and really questioning, is she sure she's not yet ready to undergo the surgery? Because the surgery does save lives. It really does prevent cancers. The surveillance is going to be a damage limitation at best. It's not necessarily going to save her life if she's unlucky enough to get cancer. So you have to be very cautious about how you introduce surveillance. But in my view, there are clinical reasons as to why you should be doing it for the women who are not yet ready mentally to have the surgery. And Hannah, I'm not sure if you wanted us to touch on the option of salpingectomy alone with delayed oophorectomy, because this may be a game changer for women in terms of limiting the morbidity of cancer prevention surgery.
Yes, I mean, I didn't really understand any of the words that you just said, but yes, please do explain
Sorry.
them.
So, apologies. This is talking about removing just the fallopian tubes and then coming back to remove the ovaries once a woman has been through menopause or is at least closer to menopause. Now, this is because over the last sort of 10, 15 years, there's been a huge amount of evidence coming out from the science world that the ovarian cancers in BRCA1 and BRCA2 gene carriers and some of the other genes that increase the risk as well, they actually start at the end of the fallopian tubes. The fallopian tubes, if you remember, are the channels that your eggs go down and get fertilized in by your partner's sperm, and then the fertilized egg ends up in the womb and hopefully grows into a healthy baby. So the only purpose of the fallopian tube is for you to get pregnant. You don't need them once your family is complete, and you could actually still get pregnant through IVF, assisted reproductive technology, even if you haven't got fallopian tubes. So if you remove the tubes, maybe you can get rid of the risk of cancer. So there are a number of clinical trials going on at the moment around Europe and in the States, for example, which we're not going to have the results for a few more years at least, probably at least 5 years and possibly a bit longer. But the hope is that these, having the surgery to remove the tubes first and then waiting for menopause or near menopause for removing the ovaries, this may enable you to get rid of most of your risk of ovarian cancer, but hopefully won't trigger a dramatically early menopause. Because this is the other crucial thing. We're assuming that by leaving the ovaries behind, it's not going to affect age of menopause. But because the blood supply to the fallopian tubes is very close to where the ovarian blood supply is, and you have to use normally some form of heat to seal the blood vessels when you remove the fallopian tubes, you may cause some damage to the ovarian blood supply, and therefore you may trigger a somewhat early menopause in the women having just the tubes removed. So these trials are looking at the levels of hormones after the tubes have been taken out to see if it is actually triggering an earlier menopause or not.
Yeah, well, thank you very much for explaining that, because I wouldn't have been able to repeat the language that you used or or any of it. So, and that's fascinating and it's crucial. It's amazing as well to see that the amount of research and trials that are underway, and thank goodness for that as well. Stina, you wanted to jump in there.
Yes, thank you very much. And then I will have to jump out because I'm actually chairing the health committee meeting in 10 minutes from now.
Oh, good. Go and tell them all about this podcast.
Yeah, I will. But just a couple of points, and I am a politician. So first of all, Adam and other people in the UK, you come back in. We have to join forces nowadays in all areas, including this area. And I will promise that as we speak, we are a lot of people working hard to make sure that in the next midterm budget for the European Union, health would have a significant chunk of budget. Because not only from defense points of view, I could have a long speech on that, but also from points of view like this. And we will get so much more knowledgeable when we work together, cross-border, seamlessly with the health data space. We've got lots of the tools, and we now also have to work much more together. And it doesn't only do a lot of good for saving lives, it also makes it much easier to be a pharma industry and to grow and to, again, supply us in Europe and hopefully also the rest of the world if the world doesn't, go completely backwards. And in that way, make sure that everybody, but in this case, of course, especially women who I really think I learned about this ovarian cancer situation some years back, and I really think there has been improvements, but we can do so much more better if we work together.
Yeah.
And thank you very much for listening in. And now I have to jump to make sure that
Stina,
we get
can I
all
ask
this
you just
fixed.
one very brief
Yes.
question just before you go, and then I'll come back to talking to Tamara and to Adam as well. We ask all of our guests on this podcast what gives you hope. In the case of ovarian cancer and changing the ovarian cancer story, what gives you hope?
What gives me hope is conversations like this. We need to educate ourselves. We need to speak much more about all the areas, especially for women's health, and especially these areas. And I really think, Tamara, it's very, very courageous of you also to tell us about, the insights of your family story, also about people not wanting to talk about this, which of course is terrible, but it is also understandable because, we have lived through many decades of if we don't talk about it, it doesn't exist. But that is, of course, never true. So thank you very much for sharing that, and I will make sure also to spread the talks about ovarian cancer also in the committee and in other areas.
Genetic predisposition. That's
Thank you.
That's the point. Genetic
Thank you.
predisposition, it's preventable, it's actionable,
Yes.
and people are
Yes.
still dying 30 years after discovery of BRCA genes.
Sure.
Stine Bosse, thank you so much. Thank you
very much. Thank you.
While Stina's just coming off the call then, Adam, Tamara, let me sort of go back to where we were before. Tamara, I mentioned before about this DISARM initiative, EU initiative, which you were talking about. And can I ask, if it's not too direct, had DISARM and initiatives like DISARM been around when you first found out about your predisposition to ovarian cancer, would it have made a difference to the choices that you've made?
No doubt about that. There was nothing around. As I told you, back in 2008, that was 4 years before or 5 years before Angelina Jolie made it public because she had the decision of her preventive bilateral mastectomy. So nobody was talking about hereditary cancer, genetic predisposition, family history of cancer. I would have loved to delay my surgical menopause, for example. As I told you, it was really a huge cut in my quality of life. It was then because of the hormone replacement therapy, which back at the time also was quite a fight to get there, because clinicians were not informed. They were still relying on an old study from 2001, the Women's Health Study. For sure, Adam is totally aware of that study that brought some great insecurities into hormone replacement therapy for women. And mostly men were deciding over our quality of health and said, no hormones, no, that's way too dangerous, and so on. But again, I did my homework. I had my background already, and I knew how to look it up and what I would like to achieve.
It sounds to me like you see knowledge as power.
Absolutely.
There will be a lot of people, though, who will be deeply, deeply afraid because maybe they've seen family members or loved ones suffer. And maybe they're really young as well, or they have young daughters and they're really scared now. You have daughters yourself, I think I'm right in saying. How have you talked to them about the options available to them or the choices that they might need to make as they get older?
So first of all, never try to hide anything from your children because they have very sensitive antennas and you cannot cheat on them. Forget about that. You need to talk openly about any issue because otherwise they feel it and they will have their reactions. I just talked yesterday to a mutation carrier who told me that the son is now peeing in the bed with 9 years because he feels there's something off, something is wrong, something is different. Mom is always, because she was diagnosed with breast cancer recently. So mom is off, she's always on the phone, she is with a very serious face, doesn't smile, and so on and so forth. There are reactions. So you need to open the dialogue with your children and you need to adapt the dialogue to their age. At the time, mine had 2 and 8 years of age. So I just told them, okay, girls, there's something in mommy's breast that could harm me. And because we don't want something to happen, I just need to take it out. No problem. Okay. I go to the hospital and they almost pushed me into the hospital. They said, go, go, get over with it.
And have they been tested now as well?
Yes. And I may say, spoiler alert, they are both negative.
Oh, okay.
Both negative. That's we just gave statistics a big goal. We are with our mutation. Our mutation is over in our family with the next generation because. That's another important thing. When you know that you are a carrier of this pathogenic variant, how it's called, this kind of mutation that can cause disease, you have options to prevent, to pass down the mutation to the next generation by fertilization in vitro. And then you select at the 3rd day in lab with 8 cells of the embryo, you can take out a cell and you understand which are the embryos free of the mutation. So a BRCA mutation is not the worst case scenario. It's still a little bit, I had a very strong family history, in fact, but there are mutations that give you cancer from childhood age on your whole life in many different sites.
I find this completely fascinating because just to sort of give my personal perspective on this, I went through a lot of IVF treatment in order to have my son, like multiple rounds. And there are members of my family who have had cancer. There is I don't think there's a very strong hereditary risk factor for me, but certainly something that, based on conversations today, I would definitely want to go and explore. But I mean, Adam, I'm fascinated by this because for women, for people who've gone through a lot of like fertility treatment, I don't remember at any point in any of those appointments anyone ever saying anything to me about hereditary risk or, when I was personally studying embryos and looking at 8-cell stages, no one at any point said, oh, do you know if you've got any kind of like BRCA1, BRCA2 things in the family that we should maybe kind of like take a look at these cells and test for? Is it just because, I mean, why is that? Why is that not?
Oh, well, I mean, I can only speak for the UK setting. Obviously, there's a cost involved, and remember, this is not being, by and large, this is not being done in this context for women who have difficulty getting pregnant. If the majority of BRCA carriers will not have difficulty in getting pregnant, so you're talking about stopping doing standard conception the way nature intended, and we're talking about converting that into a highly medicalized artificial process with no guarantee of a take-home baby, is the phrase that people use when they're talking about fertility. So the reason you're doing this very complex intervention is because you're trying to avoid your children carrying the same gene alteration that you've got. So you have to know that you've already got the gene in the family in order to be able to be in a position to test the embryo. But I suppose arguably any really responsible fertility clinic would be at the very least taking a family history carefully. And if there is a hint that there's something genetic going on, not necessarily cancer genes, it could be genes that cause congenital abnormalities or some other problem. If there is a history of that in the family, then you may want to suggest that they see a clinical geneticist who can test them first. And then if they do find that they've got a particular gene alteration, cancer causing or causing some other problem, then you can talk about this process called, in the UK, we call it pre-implantation genetic testing.
Yeah, which I had actually, yeah.
Yeah. So it is feasible. But I wonder if I could just go back to something else, which I think we've kind of not really talked about, which is we've been talking exclusively really about family history because it's an incredibly powerful story that Tamara and so many other women I've seen over the years have had about losing relatives to unpleasant diseases and often at young ages. But what we need to remember, and this is really important, is that there are loads of studies now showing that if you rely on family history alone to work out who should have access to genetic testing, you will underestimate by up to 50% the proportion of your population that have a bad gene that they could be passing down and could cause themselves to get cancer. And I've got colleagues in the UK working on this at a population level, and it looks like it's very cost effective for a country to offer testing to its entire population, men and women, because by identifying everyone at risk, you can actually prevent so many cancers that it becomes cost effective to test an entire population. So then that gets you into the really difficult questions about how do you manage that information? Because not everyone's going to want it. And many people will quite sensibly only want it if there are assurances that it won't result in things like them being denied healthcare insurance in the future. So it's a shame that Stine had to leave the conversation because I would love to have heard her take on the European view on offering population level genetic testing, because this is a problem for society, not for doctors.
Yeah, because I think it's 1 in 5 cancers is hereditary, but your point being that actually that it's not just about the hereditary factor, that if you just do the whole population, then actually it could, well, from the UK perspective,
well, it's hereditary, but it's hereditary for everyone, not just those with a family history. And it's not just cancer. It's heart disease, it's dementia, it's diabetes. There are all of these conditions where there is a genetic component that allows you to predict some, if not all, of the risk of that particular disease. So this is the future of personalized medicine, is going to be working out what your risks of various diseases are and what we can do as a medical fraternity, a medical group of people to prevent you getting sick in the future.
And as you said, a lot of people are afraid of knowing. They don't want to know if, it's like people saying they don't want to go and have a full body MOT because they just don't want to know what might be sort of down the line for them. But what sort of counselling, I suppose, or what safeguards are currently in place for women and to help women navigate knowing that they might be the carrier of, they might have one of these genetic mutations?
Well, in the UK, it would be a genetic counsellor or a genetic doctor would talk to them extensively about the implications of the testing and get them to sign a consent form that explains some of the issues we've talked about how it might affect insurance, for example. I can't speak for other countries. Tamara may have a view about what she experienced and if maybe that's changed in the last 10 years since you were tested over 10 years ago.
I can tell you that the lack of genetic literacy within healthcare professionals is actually the highest barrier to access genetic testing. So if we look at the GP, the general practitioner, the family doctor that may already follow the third generation of the same family, is in front of the whole family history of cancer. Those are the specialists that know less about hereditary cancer syndromes. They are super complex. You can relate maybe a lobular breast cancer to a hereditary stomach cancer, something like that. Who would tell that those two organs can be linked in some way? Nobody knows that. So we need to have digital support tools that help us to identify more and better genetic variant carriers. So from our side at Evita, we built over the last 7 years a digital platform called Evita Platform, which besides many other functionalities, and we won't have time to go in there, but the heart piece is a 10-question questionnaire based on our national recommendations with an immediate result if you would benefit from genetic counseling or not. Because in Portugal, if you have a medical indication, so if your GP would be educated enough to forward you to a genetic counselor, and then the genetic counselor identifies with the help of a digital tool, there you go, again, what is your risk estimated to have a hereditary cancer syndrome, and then you get your blood test done and your genetic testing done. That's all assumed by the national healthcare system if you have this medical indication. But not everybody fulfills those indications. For example, as I told you in the beginning, I knew and I know I'm from the paternal side, I'm the carrier of the pathogenic BRCA1 variant. But when my mother got her second contralateral triple negative multifocal breast cancer diagnosis 30 years later, that's like in the books for BRCA1 mutation, I called Germany again and I said, you need to test my mother because I have a brother with 4 daughters that tested negative for the paternal mutation. We may have also a maternal mutation, but there was no hint. There were no siblings. It was a small family. And back there, the generation before, they did not talk about anything. I know that the maternal aunt died of pancreatic cancer. That was the only case known. But my mother with this second contralateral and so on. So I'm a daughter of 2 BRCA1 carriers. So if we want to find out, we need to have a view out of the box a little bit. We cannot rely strictly on the family history that may not exist due to a lack of communication sometimes.
Adam, what would be the one thing that you would want women watching, listening to this to understand about hereditary ovarian cancer risk? What would be the one message that you would want them to take away from this conversation?
I think, don't put off testing if you think you need to do it. I myself had BRCA testing because I have an ovarian cancer in my family history, and for a few years I kind of just put it off and thought I'm too busy. I can't be bothered with this. I don't want the knowledge. And then as time went by, I thought, well, I could be at risk of prostate cancer. I could be at risk of pancreatic cancer. I really ought to do something about this. And I went and had the test, and thank goodness it was negative. But I'm really glad I did do the test. And had it been positive, I would have been able to get some forms of surveillance that might have saved my life. So I think it's only worth doing testing when there's something you can do about the results. But we are now at a point where we really can do so many positive things. If you're unlucky enough to carry a gene alteration, don't bury your head in the sand about it. Just get the test done, and then there will be people there that can help you.
And Tamara, if someone is concerned about their family history, what practical steps should they take first?
So as I told you, we try to solve it in a digital way. We have a Evita platform which is available in Portuguese and English. You can do your 10-question questionnaire and print out the result and take it to your GP and ask him to refer you for genetic counseling. Yeah. Later, we will have genetic counseling via telemedicine also inside the platform. It's all foreseen.
Okay.
So we want to understand who of this crowd of 150 people, who are the carriers? Wherever we talk about hereditary cancer, afterwards come 2, 3, 4, 5 people and want to talk better to us, because everybody has something in their family when they understand that every cancer before 50 years of age, if the cancer is repeatedly over several generations on the same lineage of the family, then you need to look out for it. Note down who had at what age which kind of cancer diagnosis and take it to your GP, or go on a Evita platform, do the questionnaire and print it out and take it to your GP. Be proactive, because if we wait for the others to act on it, it may be too late.
And we will put the Evita platform link within the show notes as well for those watching and wanting to know how to access that. Final question to you both. Adam, I'll come to you first. What gives you hope?
I think the speed at which medical research is driving this particular area of medicine forward, it's really becoming exponential. I've seen so many changes for the good in my career, and I can see things getting better, and I hope before I retire we'll find out that removing the fallopian tubes first is a safe alternative to having the tubes and ovaries out at the same time. We would still recommend coming back to have the ovaries out at a later date, but at least you could potentially avoid a premature menopause, and that would be such a game changer for the women that I've looked after for so many years. Not having to take away their hormones at a young age would be just wonderful.
Same question to you, Tamara. What gives you hope?
Besides everything that Adam just said, I totally agree with, of course. I feel we are in a mind shift regarding hereditary cancer. Before, it didn't have a name. Nobody was talking about it, or they were just weighing it away. That's very rare, not interesting, and so on and so forth. Now we have 3 European projects working on early detection of heritable cancers, which is SHIELD for pancreatic cancer, DISARM for ovarian cancer, and Lynch for Lynch syndrome-related cancers, which is also endometrial cancer involved. So we have this cluster in this European mission called Early Scan of these 3 projects. And that's a huge hope for me that better times will come with better early detection methods that can probably prevent the preventive surgeries for many people. It's awesome if you can keep your breasts. It's also awesome if you can keep your ovaries to go in smoothly in a natural way into your menopause, and so on and so forth. So my hopes are high. Things are happening. We are in a mind shift. European Commission woke up for the importance of prevention and early detection of super expensive hereditary cancer. And we will have first evidence on those socioeconomic costs in the final conference of European project Preventable that is looking after 8 different rarer cancer syndromes and how much does it cost to prevent those cancers versus to let it happen, then the second disease and then the metastasizing and then early onset due to metastasized disease. So better times will come. Be sure about that. Don't be afraid to know. Knowledge is power and it's actionable.
That gives me hope as well, listening to you speak and to your response to that. So Tamara Hussong Milagre and Professor Adam Rosenthal, and also to Stine Bosse, MEP, many thanks to all of you for joining us on this episode. And thank you so much for watching and for listening to Changing the Ovarian Cancer Story. As ever, we would love to hear your thoughts on the show. You can email us anytime at podcast@worldovariancancercoalition.org. If you enjoyed and found useful today's episode, please do like and subscribe. That, of course, really, really helps more people find the podcast and join the conversation. The episode was produced by Annabelle Deegan and Jessica Martinez de Hoz. And from all of us here, goodbye, and until next time, keep well. If anything in this podcast has affected you and you would like to speak with someone, you can also contact your local ovarian cancer patient group. To find your nearest ovarian cancer groups by country, please go to partners.worldovariancancercoalition.org.